Welcome back, everybody, to Diversion Insights. Today's interview will provide insight into something different, probably for a lot of you, and that is medical record falsification and cloning. My guest is Tracy Hunt. Welcome, Tracy.
Thank you, Terri.
Start by telling us a little bit about you and your background.
So I've been doing healthcare fraud for health insurance companies for give or take about 20 years with a criminal justice degree, and did some time in the military. So in the medical field, helping to lead to my continuation of just doing an investigation of looking at documentation and researching how providers do things.
Okay, perfect. And you're also the Colorado president of NADDI, right?
Yes.
Yes. Okay. All right. Shout out to NADDI. All right, so we're going to talk about record falsification. I think, in many cases when medications are diverted from patients, there's varying levels of severity, right? Patient harm is the most serious. But where I often hear, in addition to harm, where I often hear that somebody really lands in a lot of trouble is when they falsify the medical records. So I want to talk about that because that can lead to insurance fraud, right? If conviction is secured. And I think some facilities, and let's talk about this, they overlook the necessity to correct some billing. So first, what statutes define falsification of records, and can this result in criminal charges? Let's start there.
And I will start with the easiest first, which is, could this result in criminal charges? Yes, absolutely. There are, depending on the state or county, there are a gazillion different types of laws that could be, utilized. A couple of the big ones are the False Claims Act, which basically just says, if convicted, this is for submitting falsified medical records to secure improper payment from government programs like Medicaid, Medicare. Okay. Then you've got the healthcare fraud statute, which does make it a criminal offense to knowingly or willingly execute any type of scheme, falsifying records to defraud a healthcare program. You've got let me think about that, the civil monetary penalties of the Social Security Act. Sorry, I had to think about that, which just is the civil portion of submitting a false claim. Again, same thing. If you're falsifying records, then your coding that you submitted for that claim is more than likely going to be, incorrect as well.
Okay.
Then you've got the, the 18 U.S. code for false statements relating to healthcare matters. So those are probably some of the big, more federal ones. And then you have, of course, whatever your, local state or county uses as well.
Okay. And so in cases that you see, do people often get hit for all of them?
Depending on the severity, they absolutely could.
Okay. All right. What about, I think more and more hospitals, I don't know if all of them do this, but they bundle medication charges, right? And so when I'm part of an investigation, people are like, do we need to change the billing? Oh, well, it's bundled. So let's talk about that. If it is bundled, and for those that are not familiar with that, it's not an itemized list of charges for their medications, right? So it's just kind of a group fee that groups into it. So the meds are put in there. If they do have a bundled approach, what should a place do if they find that somebody has falsified records? This is just on the institution's side. Of course, the person can't take it back, but what should the institution do, and should they?
Well, and typically, if you're seeing and we'll just call it a generic, bill, they could be asking the facility or institution for an itemization. That includes, all pharmaceuticals, but that could include anything that they're bundling, whether it's labs, x-rays, those kinds of things. They could absolutely, that facility should be able to give them an itemization of what was given or done on any specific day. And if they can't, then that's definitely a suspect facility that you want to look at a little bit more, because, they obviously need to account for that for cost, but they should be also billing it, on a daily basis or at least a weekly basis, depending on what the, patient's in for.
Mhm. So, but if it's a bundled fee, and if it's a bundled fee and I have diverted and I have charted 2 hydromorphone syringes for the patient that the patient never got, but it's a bundled fee, so it doesn't matter whether I chart 2 or 10, it's the same price, right? Ultimately, from an insurance perspective, is that correct?
It could depend, because typically, even with bundled fees, you still can have an itemization, right? And we'll just make it up. Say they bundled that they gave a patient 50 Tylenol. Within that documentation, it should say the patient received, over a course of a week, 50 Tylenol. Bundled or not, you should still see that all of that is accounted for within the documentation.
Okay. Does that, if they really only received 20 though, and not 50, but the charge doesn't change, it's just the itemization.
Right. And at that point, that's more of an education. If it's, if we're going to pay you $100 for 50 Tylenol, regardless, that would just still be an education back to that facility to say, hey, yes, even though this is a flat fee, so to say, and we're paying you for one cost, but that cost is typically going to say, and I'm again making it up, 1 to 50 is this much, 50 to 100 is this much.
Gotcha. Okay, so even if it's bundled, there's a point at which if they cross over into the next range, then it does result in a higher charge to the insurance. Okay, all right. Yeah. And so what would your recommendation be if a hospital is in the middle of an investigation, they determine that there has been falsification of records, charting on the EHR that meds were given that weren't really given, then they should go in and look at that itemized and remove the ones that they know definitively were not given.
Correct.
Okay. Yeah. All right. So the healthcare professional that has done the fraudulent charting, it's too bad for them already. They can't change that, right? Now the facility has attempted to correct so that they themselves are not accused of fraud. How does this play out for the institution? I'm used to hearing these cases, whether it's a diversion case and the DEA comes in and they find all kinds of things, and then the facility gets hit with these huge penalties and fines. Does it work the same way through insurance? It's an institution on the hook for charting fraud as well as the person?
It could be, yes, because in theory, they should have some type of, quality assurance program set up, and it doesn't have to be, everybody looks at every record, but depending on the type of facility and how large, they should have some type of QA program set up to where they're, auditing notes to make sure, everything was documented and what was billed out on that specific day or week, month, whatever that case may be. And especially if they're looking at a, specific healthcare person, whether it's a nurse or a doctor, they could absolutely go and, grab all of those records. Sorry, I was trying to think of my word there, for that person to see how they're documenting compared to what they, were billing out or diverting potentially.
Yeah, I did have a case once where it was the billing department that called me and said, why would, and I don't even remember what the circumstances were, but it was a good catch from them. And it's like, yeah, you're right, that doesn't quite make sense. And so I wish I could remember what it was that alerted them, right? It wasn't just a dose of an opioid, obviously, those happen all the time. But something piqued their interest and they were spot on. Maybe it was a duplicate charting or something, and they knew that these were too close together. But anyway, it was the billing department. So they were clearly looking at, what was being billed out.
And that's good for them, because sometimes, I know I have friends that do QA for facilities, and, if you're only just looking at maybe a specific day or two, you may not catch it, but a billing department is a great area because they're looking at everything that was done and doing that billing. And And that is a great find. And those are your, key people for definitely education and training. And
Definitely need to loop them into what is diversion and what do we need
yes.
to watch for. Yeah, definitely. So what are the various methods of discovery that you and your team employ, and perhaps then the institution themselves as part of their QA can kind of keep their eye on those things too. But how do you go about looking?
So kind of like we just talked about, really it's kind of a QA of, if we're looking at it from a health insurance aspect, it may be, okay, I'm going to ask, ABC facility for all medical records for Jane Doe. And, I could do it patient by patient, or maybe we do look at it for a specific time frame. It just kind of depends on what the initial allegation is. Is it against the doctor or is it against the facility? It just really kind of looks at what was that allegation and what we might want to pull. And, we may do, that's what we call a post-pay if we're looking at it after the fact.
Okay.
There are times that we put them on what we call a prepay, which is we're going to review all documentation before we pay them anything.
Okay. All right.
And that way that gives us that better look overall at that patient, or, it's going to be patient regardless, but potentially at that, facility or that provider as well, to see what they actually documented versus what was billed.
Okay. So you will have cases where before you pay anything, you just review it. But then also if something is brought to your attention through some sort of complaint or what have you, then you do a post look for.
Correct. Yeah.
Right. Okay. And if you find something that you suspect is not looking right, what is a typical investigation process involved?
So typically we'll, if we'll just go with, we got the allegation from someone else, just to kind of make it a high level easy. We'll pull some data on that provider or that facility, just kind of looking at how they bill overall. Does anything look, out of whack, compared to what they should be billing against their peers? And if it looks like it's, pretty normal, then we'll start, potentially patient interviews, especially if we did get an allegation, we may call a handful of patients and, say, hey, just, kind of checking in to see, what happened when you were at the hospital, for these 5 days, how was your care? How was your treatment? What did you have done? And it's just more of a kind of a casual conversation, because, you don't want to let that patient know, hey, we're suspecting, John Doe or Nurse Smith, of something. And a lot of times we'll just, kind of preference that conversation with them of, we're just doing a quality audit to say, hey, how'd everything go? What'd you have done? And sometimes, patients are really good about letting you know what they did. And some are very generic. So you have to kind of probe a little bit more of, hey, did you really get those, 50 Percocet in that 3 days?
Yeah.
And they'll be like, what? Are you kidding? And you're like, oh, and then of course, I don't want to say playing it off, but, trying to backtrack just that smidgen to say, oh, sorry, I didn't mean 50, I meant 5, because then they do start, kind of freaking out. And so you just kind of have to, play with it based on how that person is when you're having that conversation. And then again, like we said, we'll do like a medical record review of, everything that they had done. If it was, maybe they saw a provider across multiple hospitals, which would be, you'd be like, well, why did you go to 5 hospitals in, 3 days? You'll try to get that documentation from all the facilities to really see, and just kind of bring it again back to that patient and a casual conversation. And, hey, did you go here? I mean, and could it be likely? Absolutely. Is it? Probably not.
Okay. Yeah.
And then we'll just, depending on how the case is, we could even potentially do an on-site audit for a provider and just, say, hey, we'll, send them the letter. Hey, we're going to be there on this date, based on contracts. We're going to be looking at, potentially 50 records. So they know that, that we're coming and to be expecting that. And, more often than not, we will kind of give them the heads up of what patients we're going to be looking at for medical records. But we, again, depending on contracts, since we are an insurance company, we have to give them so much time notice that we're coming. And we will typically try to do that as close to the date that we want to get there as possible. So there's a less likelihood of any falsification or creating medical records to substantiate what they billed.
Yeah. So I'm curious, how often, I guess I don't think of a legitimate facility. It's a true medical center and they're doing business. Obviously, they're not perfect and there could be things that happen. And there could be people within the institution that are charging for what they shouldn't charge and it gets past the billing. I get all of that. But how often does it happen that a legitimate organization has to be audited and you find things? And I guess I'm comparing that to, I recently had a friend of mine tell me that she got a letter in the mail about her insurance was paid a certain amount of money for this something. She's like, I have no idea what they're talking about. And then it just so happened that a friend of hers that same day said, look what I got in the mail. It said my, Medicare, I think it was paid for, Medicaid paid for. And it's like, two of us, same procedure, same charge, same. And it's like, okay, this isn't right. So they reported it to the local office and they said, oh yeah. And by the time we catch these people, they folded and they're gone.
Mm-hmm.
So is the majority of your stuff that you find places like that are really nefarious and they're all set up just to bill and false billing, or are they legitimate institutions?
That's a tough one. Because of course it depends on the part of the country. We do have the hot spots for that exact scenario, but there truly are some facilities that, want to do the right thing and, had no idea that their biller was doing XYZ or, the nurse or provider was billing XYZ. Where it kind of comes to be a little sticky and then they get in, into more troubles that, ultimately they're the ones submitting the claims and they're responsible for what goes out. Right. So it's really, it can get sticky. And, like I said, we've had some providers that were like, oh my gosh, I had no idea, that were honestly, legitimately didn't realize that they were billing wrong codes.
Sure.
They were like, it was one of those, well, I went to a conference and they were talking about, we should be billing blah, blah, blah. Yeah. And you're like, well, you can, however, your documentation doesn't support that kind of, code. And so a lot of times when we're doing those audits, we try not to tell the provider upfront what code they should be billing. Sure. Other than, your documentation isn't supporting the code you are billing. But there will be times when it is a true legitimate that, we work with them to identify what the appropriate code should be without us telling them. Because that's not really our job, that's ultimately their job because they're the ones that do the billing.
Yeah, that makes sense. What about in retail pharmacies? Is it mostly, do you see claims resulting from, thinking if it's a diversion thing, it probably isn't a records falsification from an insurance perspective at that point. Well, unless they're handing things to not real patients.
Well, and a lot of times with those, it's, you could call it falsification. A lot of times it's not, they don't even have documentation. They're just, they've acquired insurance information from, 550,000 people and they just bulk submit claims maybe for a week or two and stop. They've got their money, they shut down, and then they move on and, open up a new tax ID and PI, and do the same thing.
Right. Okay.
And those types of places go from, can range from, they're just going to do it for, months to years on end, smaller dollar, hoping never to get caught, to those that bill that, high dollar, chemo or, whatever those high dollar medications are for a short time just to get the money and then shut themselves down and move on.
Sure. Okay. All right. So to circle back to the healthcare professional within a hospital or surgery center that is diverting and is doing it by way of falsifying the records. It's these cases where everything makes sense, right? They've dispensed it, they've charted it as administered, and it takes a while for people to kind of figure that out. And they have no smoking gun because they're meticulous in their charting, but their amounts make you pretty sure that this doesn't make sense because nobody else gives this much, and this patient got way more. There is most likely falsification of records. The hospital can't prove it if the person doesn't admit it. Is there anything that you would recommend that should be done from the facility's standpoint and those records?
Gosh, I'm thinking really and I know, granted after the fact, by the time they're catching it, it's going to be a little more difficult. But it really is at that point, talking to that patient, right? Because they're the ones that would have gotten that medication. And then, talking to those that were around during that time.
Mm-hmm. Yeah.
Obviously shift to shift, maybe not necessarily a surgery center, but at least if you're in a larger facility, shift to shift,
Mm-hmm.
Nurse Doe would know if, patient Smith was really hurting or all of a sudden got, better. They should be able to identify those differences within the staff and within talking to the patient themselves.
Yeah. So it requires real-time identification, and that is your proof talking to the patient that they didn't get it, essentially. Right. And, I have recently actually a couple of cases that have come across my desk recently. It was the patient. They got on their my charts and they looked and they're like, I did not get that med. And I was at a hospital last week doing a gap assessment, and first time I have seen this really neat board that they have up in every patient's room, and it's connected to the EHR. Oh. And it tells them when the last time they got the pain medication, and the patient can see it. I mean, it's right there on the board. And so, of course, the staff can see it too when you're going to go in to give it, which I thought was really neat for patients that want to keep track. That, is a diversion mitigation technique, because it's just out there for the whole world to see that they just got that med. And then incorporating those patient rounds, and kind of similar to what you were saying about, you call the patient and you're, asking them questions, but I always encourage them, not just your generic patient rounds. How are you doing? How's your pain control? It's very targeted. Oh, I see here you got such and such for your back pain about an hour ago. How did that work? And then lo and behold, the patient sometimes will say, I didn't have any back pain. And then that's when you get it. So incorporating that into just the routine of the day, of the shift. Yep. Yeah.
And I noticed, when some of our investigations, when we've done some facilities, kind of, again, after the fact, kind of like what you're saying is targeting it with, oh, you got that, that Percocet, an hour ago, how was that compared to when you got the, Percocet 6 hours ago, when you're targeting, again, a specific person. And what we've seen is, oh yeah, that middle of the night Percocet didn't seem to help nearly as much until I got my next dose, which would have been shift change, right. Identifying that kind of thing too. And you're like, no, I felt like I was taking a good old Tylenol and not a Percocet.
Yeah. Yeah, no, that makes sense. We didn't talk about cloning. So I think cloning is one of those things I was not familiar with. And I think it's a way that you identify potential fraud in a chart, right? So can you just explain to the listeners what cloning is?
So cloning is it's similar to a falsification, but really what you're seeing is if it's the exact same statement, vital signs, just the same exact information visit after visit, with no changes. And we see a lot more of that within non-facility provider cases. I can say I probably haven't seen that in any facility that I've looked at, but a lot more non-facility, those that are just going in to get maybe a quick visit or a medication refill. And, whether it's the provider or the front desk, whatever, just copies exactly what was on the last visit. And all they do is change the date.
Sure. Yeah.
Sometimes I don't even change the date.
Oh, wow. Yeah. Yeah. And there's, I have a podcast coming out soon, hasn't been published yet, but we kind of talked about that. It's a gentleman that helps physicians just, mitigate their risk for their legitimate physicians and to keep the DEA out. Right. And it's all about, you've got to write your notes and you've got to talk about the visit and you've got to, so yeah, you would expect things to change from visit to visit. Yeah.
I mean, that's what we say all the time, and providers get all mad at us. It's like, you may have done that heart surgery, but what you billed was a heart surgery plus a gastric bypass, Yeah. Well, and a lot of times they're like, well, I have to do this to get to that. Well, you didn't document that. I understand you may have to, but again, if it's not documented, it didn't happen.
Sure. Yep. That's the key right there. Yep. Okay. All right. Thank you very much, Tracy, for your time. This was interesting for me. It's a space that I'm not as knowledgeable in for sure. And so reminder, everybody out there, make sure your billing department understands what diversion is and you can engage them in that monitoring piece of it because they see all of those meds. Yeah. All right. Thank you, Tracy.
Thank you.